Hi everyone. I'm very grateful today for the opportunity to speak to you about an illness that's very important to me. My name is Ayman Mobin, and I'm a final year medical student with a background in medical sciences and a growing passion for neurology, especially rare neurodevelopmental disorders. Today, I'll be speaking to you about Rett Syndrome, an often misunderstood and underdiagnosed condition that primarily affects young girls. It's a disorder that can be incredibly challenging for both the families and the clinicians due to its complex presentation and overlap with several other neurological conditions. In this talk, I'll first walk you through what we currently understand about Rett, its clinical features, the genetics, and the management. And then we'll transition into a case that I was personally involved in, which highlights some of the diagnostic challenges we still face in identifying atypical forms of this disease and closely mimicking illnesses. This case was particularly meaningful to me, not only because I got to observe how the family was affected and the quality of life for the patient, but also because it pushed me to think critically about how we apply evolving sciences to real patients and their lives. So let's begin by grounding ourselves in what Rett syndrome actually is. So, Rett syndrome is a rare X-linked neurodevelopmental disorder primarily affecting females, with an incidence of about 7.1 per 100,000 live female births. The condition was first described by Andreas Rett in 1966. He described around 22 cases of baby girls with the same atypical features, but even after his connection, it took almost another 17 years for the syndrome to be characterized and recognized in the medical community. Now, although Rett predominantly affects females, males can also be affected, typically experiencing more severe disease that often results in death in utero or shortly after birth. It's characterized by early neurological regression that severely affects motor, cognitive, and communication skills, by autonomic dysfunction, and often a seizure disorder. And there's two major categories. There's classic versus atypical or aclassic. Now, please forgive me as we delve into some molecular biology, specifically talking about DNA methylation. So, CpG dinucleotides are the primary sites of DNA methylation in mammalian genomes. CpG islands are typically unmethylated in their native form, except for sequences on the inactive X chromosome. Methylation of CpGs is associated with gene silencing and changes in chromatin structure. Methyl CpG binding protein 2, called MECP2, localizes to the X chromosome in mice and has been shown to repress transcription in vitro. Many cases of Rett syndrome are sporadic and result from de novo mutations in the MECP2 gene, usually of paternal origin. Fewer than 1% of cases are inherited. And since these mutations are of paternal origin, it may help explain why males are typically spared. MECP2 is a transcriptional regulator that binds methylated CpG sites and modulates gene expression. Specifically, it's a transcriptional repressor involved in chromatin remodeling and modulation of RNA splicing. Although MECP2 is expressed in all tissues, it's most abundant in the brain, which helps explain why mutations lead to disrupted neuronal development and impaired synaptic plasticity. I do also want to mention that there's been some new research that indicates that MECP2 may have a role in regulating neuronal activity-dependent expression of specific genes, such as HERI2A in xenopus or BDNF in mouse and rat models. These findings may offer further insights into MECP2's role in the human brain, but there needs to be more specific research done to confirm all of these facts. Now, atypical Rett variants may result from mutations in other genes, including CDKL5, FOXG1, and more recently, CACNA1A, especially in early onset seizure cases. Mutations in the X-linked gene cyclin-dependent kinase like 5 have been identified in patients with rare congenital disorders characterized by intractable early onset seizures and Rett-like features. These mutations were initially associated with early onset epilepsy and infantile spasms accompanied by severe intellectual disability. There are over 250 known pathogenic variants in MECP2s associated with Rett. Approximately 80% of those cases are due to an identifiable point mutation or a C-terminal truncation. If you look at studies using neuroimaging, neuropathology, neurochemistry, and animal models, They show a reduction in brain size and global neuronal volume, along with alterations in multiple neurotransmitter systems. Autopsy studies actually reveal a 12 to 34% reduction in brain weight and volume, with the most significant changes observed in the prefrontal, posterior frontal, and anterior temporal regions. Rett is actually considered a disorder of postnatal neurodevelopment rather than neurodegeneration. There is a noted decrease in the size of cortical mini-columns, which correlates with reduced dendritic branching in layers 3 and 5 of the frontal, temporal, and motor cortices, and layer 2 and 4 of the subiculum. Now, neurophysiological studies of Rett patients suggest an involvement of both the central and the autonomic nervous system, while the peripheral auditory and visual systems remain intact. Evoked provincial studies show altered somatosensory responses. EEG findings reveal focal, multifocal, and generalized epileptiform changes, as well as rhythmic slow theta activity, all of which point to an altered cortical excitability. However, EEG patterns are not diagnostic and they vary widely based on the patient and the disease stage. Now, the fact that MECP2 mutations can cause not only Rett, but also a spectrum of neuropsychiatric phenotypes, and that either loss or duplication of MECP2 results in disease, suggests that even a minor regulatory mutation or post-transcriptional change may lead to a more limited feature, such as an autism-like condition, seizures, Parkinson features, or cognitive impairment. Now, clinical features and staging of Rett syndrome. These patients present with normal development and milestones, followed by regression. There are 4 major stages, as you can see on screen. There is early onset with stagnation, rapid regression, plateau, and the late motor deterioration. The hallmarks of the disease include regression in motor and speech skills, hand stereotypes of ringing or clapping, gait disturbances, seizures, breathing irregularities, sleep issues, scoliosis, and growth delay. Now, let's talk about stage 1, which is early onset stagnation in development. Most children initially meet developmental milestones, but one early sign is deceleration in head growth, leading to microcephaly by age 2. Language skills may develop briefly through learning 1 or 2 words, but then they regress. Communication is often maintained through eye gaze, body language, and facial expression. Then we move on to stage 2, which is usually when children are between 1 to 4 years old. This has a loss of purposeful hand use and speech, accompanied by the onset of hand stereotypes including ringing, clapping, and mouthing. Microcephaly is accompanied by general growth retardation, weight loss, and hypotonia leading to weak posture. Rett typically exhibits 5 growth patterns, which range from severe, normal, or moderate somatic growth with microcephaly, or normal growth and moderate somatic growth failure with normal head size. Compared to typical Rett, atypical tend to have more patients with normal head growth. Feeding impairments such as difficulty chewing, swallowing, choking, nasal regurgitation, or upper GI dysmotility may contribute to growth issues. Along with feeding impairments, there could be inadequate nutrition intake for children as well as alterations in energy expenditure compared to other children, which leads to their growth concerns. Patients may also exhibit social withdrawal, irritability, and self-injurious behaviors. Autistic features that they may present with include expressionless face, hypersensitivity to sound, lack of eye contact, indifference to surroundings, and unresponsiveness to social cues. The earliest autonomic symptoms are disorganized breathing patterns during wakefulness, which are characterized by periods of apnea alternating with periods of hyperventilation. And although there is data on the respiratory symptoms, it's quite limited, and some studies using CTs show that patients may be at increased risk of interstitial lung disease and respiratory dysfunction. Now, stage 3, which is between 2 to 10 years, is the plateau phase. Motor issues and seizures usually dominate. One of the most artist features of Rett is the occurrence of seizures, which range from easily controlled to intractable epilepsy, with the most common types being partial complex, myoclonic, and tonic-clonic seizures. While the prevalence of epilepsy in patients actually increases with age until the teenage years, seizures tend not to occur before the age of 2 in typical Rett. They tend to lessen after the teenage years. Gait becomes broad-based and ataxic, with patients often rocking back and forth while sitting or standing. Most girls lose mobility and become wheelchair-bound in their adolescence. And autonomic issues such as hypotrophic cold blue feet, constipation, oropharyngeal dysfunction, and cardiac abnormalities like tachycardia, prolonged QT, and bradycardia suddenly appear. Sudden unexpected death from cardiac instability is much more common in Rett than it is in the general population, and extrapyramidal symptoms, including bruxism, drooling, oculogyric crisis, hypomimia, dystonia, rigidity, bradykinesia, and proximal myoclonus also exist. Now, stage 4 is when the child is usually more than 10 years old, and it's the late motor deterioration. As patients age, Parkinsonian features emerge such as motor deterioration, generalized rigidity, and dystonia. Despite normal appetite, patients tend to lose weight and may develop osteopenia. The cause of this reduced bone density remains unclear, but it does increase the risk of fractures. Behavioral issues such as bruxism, screaming fits, night laughing or crying, and anxiety is usually triggered by external stressors. By age 11.5, most girls develop scoliosis, and some genotypes are actually associated with milder or more severe disease prognosis. The condition often plateaus, with some patients surviving into their 60s with a profound, debilitated state. Now, there's also 3 main types of atypical Rett that I would like to mention. There is preserved speech variant, which is where patients retain verbal ability and usually exhibit milder symptoms. There's early onset seizure variant, which is when epilepsy begins between the first week and the 5th month of life. And then there's the congenital variant, where symptoms appear within the first 6 months of life. Now, as we move forward, let's talk about the diagnosis and further on what the management is. So Rett is often based on the clinical criteria of loss of hand skills, speech regression, gait abnormalities, and the hand movements. In 2010, though, a formal criteria for typical and atypical Rett was established. Diagnosis requires comprehensive clinical history, physical exam, and genetic testing. And while taking history, it's very, very important that special detail is given to the timing of the developmental milestones and when the patient experienced regression with a loss of hand skills and spoken language. MECP2 sequencing is the standard. If it's negative, then test for CDKL5 or FOXG1. If that is still inconclusive, then whole exome sequencing is necessary to rule out mimicking diseases. Other tests can also be conducted if the diagnosis can be made through genetic testing. There's brain MRI, serum amino acids, urine organic acids, EEG, and genetic testing for other illnesses like Angelman. Usually a diagnosis made in the middle of childhood is very simple and straightforward. However, in early infancy, diagnosis is actually very difficult as several symptoms of regression haven't even presented yet. There have been several factors that delay the diagnosis of Rett, such as the normal head size, less specific symptoms presentation, age of the onset of symptoms, and lack of regression of hand use or verbal languages. So, first I'll talk about what the main criteria of Rett is. There's 4 major things. There's partial or complete loss of acquired purposeful hand skills, partial or complete loss of acquired spoken language, gait abnormalities, and stereotypic hand movements, such as the ringing, squeezing, clapping. And then we can move on to the supportive criteria, which is usually used for atypical Rett. There's breathing disturbances, bruxism, impaired sleep pattern, abnormal muscle tone, peripheral vasomotor disturbances, scoliosis, growth retardation, small, cold hands and feet, inappropriate laughing or screaming spells, diminished response to pain, and intense eye communication. And there's an exclusion criteria, which states that brain injury secondary to trauma, neurometabolic disease, or severe infection, as well as grossly abnormal psychomotor development in the first 6 months of life, excludes the patient from having Rett. Now, typical Rett will present with all 4 of the main criteria met and a period of regression followed by recovery or stabilization, whereas atypical Rett will present with 2 out of the 4 for the main criteria and 5 out of the 11 of the supportive criteria met, along with the period of regression followed by recovery. Other differentials that we could consider include autism, encephalitis, PKU, urea cycle disorders, Angelman syndrome, and cerebral palsies. An important and often misstep in management as we move forward is counseling and support of the patient and their family. Education, healthcare programs, discussing caregiver burden, and providing resources and advocacy for the families make a very large impact. Nutrition is important to monitor every 6 months for Rett patients who should be given a high-calorie, well-balanced diet with vitamins. Chewing and swallowing difficulties need to be assessed early through occupational therapists. And to improve bone quality, calcium and vitamin D supplementation can be started if the intake supplies are low. For children who meet osteoporosis criteria, bisphosphonate therapy can be started. For scoliosis, there is no ideal treatment as of yet. Anti-seizure medications can be used for seizures, and there has been some evidence to show that a ketogenic diet or vagus nerve stimulation can improve intractable seizures. There is no treatment for breathing disturbances yet, and cardiac abnormalities can be avoided by avoiding medication that causes prolonged QT. Now, on March 10th, 2023, the FDA approved oral trofinetide, which is also called Daybue, for Rett patients age 2 or above. The Phase 3 Lavender trial showed significant improvement in both caregiver and clinician-reported outcomes. Trofinetide is a synthetic analog of glycine, proline, and glutamate, which is the N-terminal tripeptide of insulin-like growth factor. And while its mechanism of action isn't completely understood, it is believed to act as an anti-inflammatory, antioxidant, and trophic molecule which stabilizes dendritic morphology, synaptic protein synthesis, and neuronal signaling. The most reported adverse effect of the medication was diarrhea, which did cause 18% of those affected to discontinue the medication. And gene therapy like TSHA 102 in Canada and precision medicine targeting structural MECP2 variants are underway. So while there is no definitive cure, the care currently involves seizure control, physiotherapy, speech therapy, nutritional support, orthopedic monitoring, respiratory care, and frequent cardiac screening. Now, as we move on, the case that I present today is a complex case of a 17-year-old patient with the clinical diagnosis of Rett syndrome, but inconclusive genetic findings, suggesting either a new variant of the MECP2 gene or an undiagnosed mimicking disorder. And despite classic Rett-like features, including developmental regression, repetitive hand-wringing, and severe cognitive impairment, the genetic testing has revealed a heterozygous variant of unknown significance in the MECP2 gene, which complicates our definitive diagnosis. This case underscores the need for caution in diagnosis and the potential significance of previously uncharacterized mutations. Now, if we move on to the history and the clinical course for our patients, the patient named AM was born from a non-consanguineous family with no immediate genetic history. However, they displayed delayed development and neurological abnormalities by 6 months of age. Despite a normal pregnancy and birth, symptoms like excessive startling, absence of vocalization, delayed sitting, and frequent aspirations were noted. And by age 5, she exhibited minimal communication, limited social engagement, hand-wringing, and self-injurious finger biting. Her mother complained that she wanted to walk all the time and the child was always zoned out. She didn't present with microcephaly, and nor did she have any dysmorphic features. She was initially suspected to have autism spectrum disorder, but she presented with her first seizure at the age of 3. Between the ages of 6 and 8, she was diagnosed with autism and ADHD. Her symptoms had intensified with further language regression and no response to valproic acid treatment. Hand-wringing and sleep disturbances became prominent, aligning her symptoms with Rett's clinical criteria. Genetic testing at 7 years identified a heterozygous variant in MECP2 gene, specifically the missense 641 C to A mutation, which converted alanine at codon 214 to aspartate. Yet this variant's pathogenicity remained undetermined. She was diagnosed with schizophrenia at this point and began glycopyrrolate for excessive drooling. An EEG was done, which indicated moderate diffuse cerebral dysfunction. Now, as she moved on as she aged between the ages of 9 to 12, her condition continued to deteriorate, with daily staring spells leading to falls, increased hyperactivity, and abnormal EEG readings. Trials of risperidone, clonidine, and atomexetine were unsuccessful. And despite no new treatments, her symptoms persisted, severely limiting her functional and cognitive capacities. Her MRI brain, however, was normal, and there was negative metabolite screening. She also at this point presented with insomnia and sleep disturbances, and she switched to scopolamine patches for excessive drooling. Now, at the age of 17, this patient is wheelchair-bound. She's nonverbal and entirely dependent for her daily activities on 24-hour assistance. Her family sought genetic counseling, but despite extensive testing, her MECP2 mutation remains classified as a variant of unknown significance due to the limited global reporting of similar cases. At this point, she is still on risperidone, she's on scopolamine, vitamin D3, and melatonin. The family wishes to trial trofinetide, pending further genetic clarification. At this point, in terms of her physical exam, she still presents with normal head size, but she has thickened skin on the dorsum of her hands from repeated biting. Now, in terms of her genetic testing and its limitations, the patient underwent next gene sequencing in 2024. The data was found on 302 genes that could be used to explain epilepsy. Sequence and copy number variants were reported based on the Human Genome Variation Society, or the International System of Human Cytogenic Nomenclature Guidelines, and based on her result, she was heterozygous C641C to A mutation, which specifically is a missense mutation. It converted an alanine to aspartate on codon 214. This variant was absent from the genome AD population. However, based on online computational programs, it can be inferred that it could cause a deleterious effect on the gene or its products. The microarray was negative, and her metabolic workup was also unremarkable. It was suggested that follow-up genetic screening be done on both of her parents to test for the variant to ensure that it was de novo in the patient. Her mother completed the testing and didn't have the variant, but due to personal reasons, the father refused. However, now we faced a challenge, because if the father had the same VUS, then we know that our patient has a benign variant and not Rett. But if he doesn't, she could have a de novo mutation which is causing Rett and has not been identified yet. So as of right now, these are the managements that she's currently on. Now, let's talk about why this case is important and why it's a unique case. This case of the 17-year-old girl, she has all the clinical diagnosis for Rett, but she has inconclusive genetic findings, which bring forth insight into the limitation of our current diagnostic and treatment approaches for neurodevelopmental disorders, particularly for conditions that are complex and variable like Rett. The patient's clinical history aligns closely with characteristic stages of Rett, including her early developmental stagnation, the regression of her motor and communication skills, the stereotypical hand movements, and severe cognitive and functional design. These features initially led clinicians to consider autism a common differential diagnosis for Rett, particularly in females with developmental delays and social disengagement. However, the subsequent appearance of hallmark Rett features, such as repetitive hand movements and language regression, along with her gene variant, shifted the diagnostic focus. This case highlights the diagnostic ambiguity when clinical symptoms overlap with conditions like ASD and other neurodevelopmental disorders. The initial misdiagnosis of autism reflects this overlap, which underscores the need for heightened clinical awareness of Rett's variable presentations, especially in the absence of definitive genetic confirmation. This diagnostic ambiguity is further complicated by the fact that the patient's mutation remains unclassified. Since not all Rett cases have identifiable mutations, this variant may suggest either a very unusual form of Rett or a disorder that phenotypically mimics Rett but arises from a different, perhaps less understood genetic pathway. So while it would be easier to make a final diagnosis if we had her paternal genetic test, unfortunately in the real world that isn't always the case. We shouldn't be limited in making a diagnosis solely based on the inability for a parent to be tested. She did meet all four of the main criteria for Rett along with several of the supportive ones, such as impaired sleep pattern, growth retardation, inappropriate screaming spells, and abnormal muscle tone. Now, this case also needs to talk about the importance and the implication of variants of uncertain significance in the MECP2 gene. These mutations are typically de novo, and they involve well-documented pathogenic variants, making the discovery of an uncertain variant, such as this one, noteworthy. If this mutation proves to be pathogenic, it could expand the list of Rett-associated mutations and contribute to a broader understanding of Rett's genetic diversity. However, if further genetic testing reveals that the father also carries this mutation, it might imply a previously unrecognized heritable condition that mimics Rett rather than being Rett syndrome itself. Now, the uncertain genetic findings also complicate our therapeutic decisions. The patient's severe functional decline and self-injurious behavior prompted trials of antipsychotics and ADHD medications, which were either ineffective or poorly tolerated by the patient. This highlights the difficulty in managing symptoms in cases where ambiguous genetic diagnosis where traditional Rett treatments may not be as effective. The parents' interest in initiating trofinetide, which is the new novel therapy that's come out, further underscores the need for access to innovative treatments for cases where the conventional approach just fails. However, without a clear genetic diagnosis, there remains uncertainty regarding the appropriateness and the potential efficacy of trofinetide in this case. This case also exemplifies the diagnostic complexity and the risk of diagnostic overshadowing in neurodevelopmental disorders. Initially, this patient was labeled as an autistic patient. She presented with early social disengagement and developmental delay. Most of these features overlap with Rett. Moreover, many Rett mimickers, including Pitt-Hopkins or the CDKL5 deficiency, can present similarly in infancy. This case emphasizes the importance of serial developmental assessments, vigilant clinical observation, and the need for clinicians to maintain a high index of suspicion for Rett when regression occurs after a period of normal development. And the emergence of targeted therapies such as trofinetide marks a promising shift in the management of Rett syndrome, offering the potential to modify disease progression rather than simply alleviate the symptoms. However, cases like the one that we're discussing here raises an ethical and clinical challenge around access to such therapies. In many healthcare systems around the world and clinical trial protocols, eligibility for novel treatments is tightly linked to the presence of genetically confirmed pathogenic mutations, and most often in MECP2. So this creates a significant barrier for patients with variants of uncertain significance, or those lacking access to full parental genetic data, as is the case in our patient. Despite exhibiting the hallmark clinical features of classic Rett and fulfilling the diagnostic criteria, the absence of a classified pathogenic variant in this patient limits access to experimental or approved therapies, including trofinetide. So this now raises a very critical question. Should the eligibility for disease-modifying interventions depend strictly on the genotype, or should our clinical phenotype be given equal consideration in decision-making? As our understanding of the genotype-phenotype spectrum in MECP2-related disorders evolves, so too should our criteria for therapeutic access, especially in rare disease populations where a rigid framework risks excluding those who may benefit the most from it. So that's all I had for you today on Rett, and now I'll be taking any questions that anyone may have.